Hi all. Good evening. Welcome to the second session. So here my topic we will be discussing on the mechanical power of the ventilator. Basically, I presume that we are all attending the exams, and this is the not the review. This is not the pure theory class, but it is how if this question comes, how we are supposed to answer. So basically, I have made a notes of this on the mechanical power of the ventilator. I hope my handwriting is legible. So the mechanical power of ventilator, what does actually it means? It is, we all know that mechanical ventilation, it's a life-saving therapy in patients with acute lung injury. And also we know that the ventilator per se can cause the lung injury, and it is termed as ventilator-induced lung injury. It is not clear, it is not clear how do we minimize this while through a multiple adjustments, such as we know so far we know that we can adjust the tidal volume, we can use the PEEP, we can limit the plateau pressures, and nowadays it is a driving pressures. This is just a background or the introductions what we need to write before starting any answers. So here we know that here the ventilator, it is a life-saving measures, yes, but also has some drawbacks. For example, that is a Wiley. It can be anti-electrotrauma, it can be a barotrauma, it can be patient self-inflicted lung injury, and biotrauma. Together, we all known as Wiley, ventilator-induced lung injury. How does this Wiley occurs? It can be minimized by the reduction of the tidal volume, mitigation, limitation of your P flat, and the delta pressure, that is nothing but the driving pressures. From this diagram, we get to know that no single parameter provides the clear indication for the onset of the Wiley. When the Wiley occurs, how does it onset, and all those things, we are not sure. So what concept arrived is the mechanical power of the ventilator. What exactly the ventilator is, the mechanical power of ventilator means that it is the amount of energy that has been transferred from the ventilator to the respiratory system of the lung. So before we begin the concept of the mechanical power, here is some timeline from the ventilation per se. In 1744, positive pressure ventilation was first coined by John Fothergill. Apart from that, in 1973, we got to know what exactly the barotrauma is. In 1993, some certain animal models such as piglet model showed the ventilator can also cause injury. In 2000, we know that the famous ARMA trial or the ARSNet protocol has come, which has limited the ventilator induced, which has limited us the low tidal volume, which has given us the importance of the low tidal volume. And in 2008, we have something concept of the transpulmonary pressure. And in 2015, we have got the concept of driving pressure. So, uh, and apart from that, in 2019, recently, there is something called as AI modeled ventilation. This is the one of the newer thing, which is called as a Neo Ganesha. This is available in Dragon machine. So the concept of the mechanical power of the ventilator comes from the first law of thermodynamics, which states that energy can neither be created nor destroyed, but can be transferred from one form to another. See, for example, in this picture, what we can see is that the ventilator has an electrical energy. From the electric energy, we have something called as a potential energy, and then that is converted into the kinetic energy, and that is driven by the bellows that produces a pressure, and that gives certain volume, and this all energy is transferred into the patient lungs. So this heat is a side effect. Heat is not per se an energy; it is a bystander or a product. So this is called as energy is transferred to the respiratory system.
Huh? Okay.
So there is something called as the ergotrauma. Ergotrauma is nothing but the amalgamation of all the traumas. That is nothing but the chrono injury. We also should be emphasized that the increase in respiratory rate per se can also cause injury. That is called as chrono injury. And the volutrauma by the high tidal volume, and then energy trauma, at electrotrauma, heliotrauma, that is nothing but the resistance and the flow, and the PEEP can cause barotrauma. High PEEP can cause barotrauma. So the basic definition of the mechanical power is the amount of energy that is transferred from the ventilator to the patient per unit time. It is a measure of time. Per unit time is important. That is nothing but the mechanical power of energy. What is the safe target of the mechanical power of energy? It is less than 17 joules per minute. So Now the definition of the mechanical power or work is it is the amount of energy transferred from the ventilator to the patient's respiratory system per unit time and is measured in the joules per minute. This is what the simplified mechanical power of the ventilator is. It is nothing but 0.098 into the tidal volume into the respiratory rate into P plus 0.5 of the driving pressure plus P peak minus the P flat. Here we can get the two components basically. It is an elastic component and the resistive component. Okay, the elastic component can be further divided into static and the dynamic. This part gives us the static elastic component, whereas delta P gives the dynamic elastic component, whereas remaining part P peak minus P flat gives us the resistive component. So what is the greatest influence of the mechanical power on the on this amongst this is the elastic dynamic component than elastic static component. Resistive component gives us the least this thing on the mechanical power of the ventilator. From the above equation, what we decipher is that sole maintenance of your P flat to less than 30 centimeter of water is not enough to prevent the ventilator-induced lung injury, and so as the transpulmonary pressure. See here, this is the diagram, which is the nothing but the mechanical power of the ventilator, which has an elastic component, which has the resistant component, and you can see the trauma increases by increasing the tidal volume, and this, to certain extent, you can see the trauma decreases by the decrease in driving pressure. So how does the driving pressure puts hold on the mechanical power? We'll discuss in later. For now, let us see what evidence say. In 2018, Sarpa et al. Done the two observational studies, which they showed that from the Mimic3 database, they showed that increase in mechanical power increases the ICU mortality, increases the ICU length of stay, and decreases the ventilator free days. So even with constant low tidal volume and the constant driving pressure. So no, only tidal volume or driving pressure or the respiratory rate do not put hold on the mechanical power, but it is the all the trauma, all the injuries or that we have discussed previously have a bearing effect on the mechanical power. Similarly, Cressoni et al. In the 2016 showed that at fixed tidal volume and the respiratory rate, if the mechanical power is more than 12 joules per minute, increase the risk of Wiley in piglets. So from this, we know that no single parameter will not have a bearing effect on the mechanical power. Any increase in the mechanical power per se will have bearing on the mortality. What are the further evidences? Yes, these are the all the retrospective trials. Guerin et al. In 2016 studied in 787 patients, database from the accuracies and the Procedure trial. They show that increase in mechanical power increases the hazard ratio by 1.03. Discussed previously, Sarpa et al. Need not have to emphasize more on that. One more thing is that Zhang et al. In 2019, who studied in 5,000 odd patients, included 8 RCTs, they calculated the mechanical power based on the predicted body weight, not the absolute. Okay, what they found that calculating the mechanical power based on the predicted body weight is superior to absolute numbers. For example, we know that the mechanical power of less than 17 joules per minute will have a good outcome. Here, the Zhang et al. Say that it should be rather calculated based on the kg, patient's kg, rather than absolute number. So one thing I would like to emphasize that these are all the computational models and that are taken retrospectively. Another trial that's Zhang et al., which we have seen that here you can see the average mechanical power based on the predicted body weight was 0.32 plus or minus 0.14 joules per minute per kg body weight. If this is in this range, then the mortality rate is decreased. And they also found that, see, in this forest plot, we can see that driving pressure has more bearing effect on the mechanical power than elastic static parameters. Last comes the resistive parameter. You can see in this last graph where the driving pressure has 4 times more bearing effect on the mechanical power than the respiratory rate. This is what that has been emphasized in this study. So how does the driving pressure helps reduce in reduction of the mechanical power? Just this is because it has more by reducing the mechanical power by 1, it can reduce the reducing the driving pressure by 1, it can reduce the mechanical power by 4 times. This is what it is. Okay, so what are the strategies to optimize the mechanical power? One, definitely reduction in the carbon dioxide. Gone are those days where they think that we can have a permissive hypercapnia. Yes, still we have a permissive hypercapnia, but beyond certain point of the carbon dioxide, say for example more than 65, it has an increase in the mechanical power of ventilator. For that, we have to optimize the sedation. We have to utilize proper analgesics is to be needed, paralysis and the fever control. And how can we increase the efficiency of the ventilator? One, by reduction of the dead space, and by matching the tidal volume and the respiratory rate. How can we reduce the dead space? By prolonging the end respiratory pause, by definitely by prone ventilation and PEEP optimizations. Whereas the best match between the tidal volume and the respiratory rate can be given by the adaptive support ventilation. So here, Becher et al. Have done the study where they have shown the bearing effect of the carbon dioxide on the mechanical power of the ventilator with the adaptive support ventilation versus the conventional ventilations. You can see the adaptive support ventilation has lesser mechanical power when compared to conventional mode of ventilations. This study supports that adaptive support ventilation reduce the mechanical power by adjusting the IE ratio based on the patient's need. You can see the adaptive support ventilation, it plots a graph here. So this is the graph where the ventilator plots a graph and adjusts the inspiratory to expiratory ratio and based on the patient's compliance so as to mitigate the increase in the mechanical power. Despite all these measures, right, by adjusting the respiratory rate, by adjusting the driving pressure, PEEP optimization and all, despite this, even if the Wiley is increasing or the mechanical power is increasing, then we have something called as the ECMO, and ECMO definitely gives us the opportunity of reducing the mechanical power. How? Definitely, ECMO is nothing but the membrane which has a membrane lung. That by providing the ECMO to the patient, we can adjust, we can go to the respiratory rate up to 10 and we can decrease the tidal volume, for example, to mitigate the peak and 20 centimeters of water. Okay. So thereby reduction in the mechanical power, and also by introduction of your ECMO can mitigate the permissive hypercapnia.
हिम्मत नहीं कर पा रहा था
Can mitigate the hypercapnia by mitigating the permissive hypercapnia. If, for example, despite all these measures, proning and all, if the PCOT is more than 60 mmHg and which has increased the mechanical power of ventilator, then you can consider the ECMO. What are the trials related to it? Yes, there is one trial. It shows that any increase in the mechanical power of more than 23 joules per minute, plus or minus 35, they have introduced the ECMO versus non-ECMO. You can see the mechanical power has drastically reduced in this. Whereas in non-ECMO group, nothing. See, the mechanical power was 13 plus or minus 9 joules per minute. So ECMO provides rest to the lungs, therefore reducing the mechanical power, and certain further studies are needed to support this. To summarize, gone are those days where we have a low tidal volume, low P flat, reduction of the P flat and the delta pressures. Yes, they have a certain bearing on the Wiley, but something new we have to find. That is nothing but amalgamation of all the insults that are happening to the patient's lung, and that is denoted by the mechanical power. And we should be mitigating the mechanical power or limiting the mechanical power to less than 17 joules per minute. So until now, this I would like to emphasize, until now, the respiratory rate was under-emphasized in various trials or clinical practices. But now the concept of understanding of mechanical power, any increase in respiratory rate plays a causing role in Wiley. Therefore, permissive hypercapnia should be relooked as increase in PCO2 can increase in the mechanical power. Thank you. I am open to questions.
That's a great talk, Raghavendra. And especially from the exam perspective, if you look at it, there are multiple things we learn. One is the
the importance of chrono injury. Chrono injury is something which is not known much about that, and the role of respiratory rate on mechanical per se in turn, which will affect the lung. There are a lot of new concepts also you introduced. Okay, looking at that, I think those are important from the exam perspective as well as from the clinical perspective also. I think he has given more than enough information on the mechanical power per se in this discussion. What he's going to do is he's going to they share the notes also, so that in the exam you can sum it up and decide what all points you want to cover and what all points you don't want to cover. It is quite exhaustive, and take a call on that. Any questions are there, you can ask.
Sir, good evening.
Okay, you can ask, please.
Sir, in mechanical power, which factor is most influential, sir? Sir, because this mechanical power formula is incorporated almost all the factors which would causes ventilator-induced lung injury, like respiratory rate, blood pressure, almost everything. So, sir, among this, which factor is the most influential increasing the mechanical power, so that we can little bit concentrate on that, like. Have you got the
So as discussed in my talk, I have discussed that the most important bearing effect on the mechanical power is your driving pressure. The driving pressure should be less than 50 centimeters. And it has shown that the driving pressure has 4 times more bearing effect than your respiratory rate on mechanical power of the ventilator.
Okay. Okay, sir. Thank you.
That's great. What we'll do is we'll go into the next topic. Next topic is the damage control resuscitation. Okay, it is by Dr. Rajat Adri. Dr. Rajat Adri is a critically consulted in Manipal Hospital, Millers Road. Is okay. Is a consultant in Manipal Hospital, Sajapur Road. He has finished his DM critical care from AIMS, New Delhi. Dr. Rajat, you can take over.
Okay. Can you hear me, sir?
Yeah, we can hear you. You can see the slides also.
Thank you for this opportunity, Rajvardhan, sir. Let us dive straight into the topic. So I have a small disclaimer. It's an exam boot camp, but my personal belief can come in between. So I want to make you guys understand what is damage control resuscitation. And then in the end, we'll conclude saying how to write it on the paper. So why DCR? So what do we do when patient is bleeding? Patient of trauma has come to the ER. So it's a reflex to say that give some fluids, give 500 ml, give 1 liter, whatever it is. So is giving fluids enough? So the whole point of giving fluids is to increase your cardiac output. So by increasing our cardiac output, we are not doing anything. So the ultimate goal is to increase the oxygen delivery to the tissues. So can we fix it by giving fluids? No, it's just a temporary fix, and it will give us a temporary brief period where we can order the blood products and everything. So it does not increase the oxygen delivery to the tissue, and large volume resuscitation worsens the lethal triad. So what is lethal triad? So it's triad of death, which composed of coagulopathy, acidosis, and hypothermia. There is diamond of death also, where hypocalcemia is also involved. So there is this is a brief overview of how trauma-induced coagulopathy is there. So there is severe trauma, which leads to bleeding, which leads to tissue hypoxia. Tissue hypoxia can lead to acidosis, which is lactic acidosis. So then, as a reflex, we try to give colloid or crystalloid infusion or massive RBC transfusion, since you guys know now that it does not lead to oxygen delivery. So anything of this kind can lead to dilution of coagulation factors and platelets, and can lead to, because of giving cold RBCs and cold fluids, it can lead to hypothermia. So this ultimately leads to coagulopathy. So the triad of death is here because of that. And severe trauma itself causes maladaptive response, leading to dilution of activation of coagulation factors and consumption of coagulation factors, consumptive coagulopathy. So in 1971 was the first description of acute coagulopathy of trauma. Then in 2007, it took almost 40 years for the concept of damage control resuscitation to come. So let us dive into the components of DCR. There are 4 components majorly, and let us understand what each component tells us. The 4 components are permissive hypotension and restrictive fluid administration, hemostatic resuscitation, rewarming or maintaining the temperature, and arrest of hemorrhage by surgical and non-surgical techniques. So let us understand how much fluid to administer. So we don't know, there is no robust evidence for this. So practical approach is to limit to 500 to 1000 ml. And fluid administration is associated with a lot of harm. It can lead to dislodgement of soft clots, dilutional coagulopathy, edema everywhere, fluid overload, and compartment syndrome, electrolyte abnormality, and hypothermia. This is the reason why we want to avoid excessive fluid administration. So coming to what is permissive hypotension. So you accept a lower blood pressure. How much? The target systolic blood pressure will be around 80 to 90, but it does not go below that, and this leads to lesser clot disruption and lesser bleeding. So how long can we tolerate this? Maximum 8 hours is what some of the studies have shown, but you have to limit it to as low as possible. You cannot go and keep the patient on permissive hypotension for as long as possible. Okay, so it has to be a balance between minimizing crystalloids and avoiding hypotension. So there are some contraindications also to permissive hypotension. We can't accept hypotension in all the patients. So some of the contraindications will be head injury, as we know that we need to keep certain cerebral perfusion pressure, and pregnancy, obviously we don't have data, and compartment syndrome, it leads to worsening perfusion in the compartment area. That's why we need to avoid permissive hypotension. And if there is one more option to write, then you can even consider pediatrics as a contraindication to pediatric patients as contraindication to permissive hypotension. So coming to hemostatic resuscitation, as I told previously, trauma causes maladaptive response to tissue destruction, leading to endogenous coagulopathic state. So the trauma itself can cause to consumptive coagulopathy. So what are the components of hemostatic resuscitation? Early administration of tranexamic acid, balanced transfusion of blood products in fixed ratio, and activation of MTP, massive transfusion protocol. These are the 3 components. So each component, Tranexa was proven in a very large trial, CRASH 2, it has very important trial. So 20,000 odd patients at risk of bleeding, tranexamic acid versus placebo. The risk ratio was 0.91, statistically significant, clinically significant. And one more most important thing is subgroup analysis of this trial showed us that if you administer tranexamic acid within 3 hours from the injury leads to after 3 hours from the injury leads to increased mortality. That means if patient has a trauma at 6 o'clock, maximum till 9 o'clock you can administer tranexamic acid. Otherwise, it leads to more injury by by promoting clot formation. So coming to fixed ratio administration. So initially we got a trial which was prospective observational trial, prompt trial. So it showed us that 6-hour mortality was lesser and everything. So what have we taught? Observational study, lot of confounding factors. We cannot take it at its face value. So we will ignore prompt trial. So the same team conducted another trial, proper trial, which was a randomized control trial. Randomized control trial must be superior, obviously, right? 680 patients. So what is the conclusion? No significant difference. We'll stop it there. No significant difference doesn't matter to us, right? But we'll look at the Kaplan-Meier curve here, where probability of death is plotted against time to death from randomization. So if you see this difference is visible to eye, those not statistically significant, this difference was around 4%. So this is for 24 hours and this is for 30 days. So if you see, this difference persists at 30 days also. So even though it is not statistically significant, it is very clinically significant for us. And that is why we need to apply it on a day-to-day basis where we give it at a fixed dose. The group with 1:1:2, where RBCs are transfused more than FFP, had higher mortality at 24 hours and even at 30 days. So what is massive transfusion protocol? So first we need to understand what is massive transfusion versus massive transfusion protocol. Massive transfusion is just a random definition of where we give so many blood products in 24 hours or 3 hours or 1 hour, whatever it is. Doesn't matter to us clinically, it's a retrospective definition, prospectively nothing for us. So what is massive transfusion protocol? It's an institutionalized protocol where we have a certain trigger of initiation and certain trigger for termination. So that means the patient coming to us with so much of bleeding, we activate based on an institutionalized protocol. There are various scoring systems. Massive transfusion protocol itself is a big topic to be discussed. I'll not go into the depth of it. And termination also has to be based on a protocol. So what we do, administers fixed ratios of RBC, FFP, platelet, and also cryo in this. So suppose you activate a massive transfusion protocol. So every 15 minutes or every 30 minutes, based on your institutional protocol, the blood bank sends you irrespective of whether you order blood or not. Maybe like 4 RBCs, 4 FFP, 4 platelet, and 10 units cryo, something like this, depending on your protocol. So in this, you have to review patient was on anticoagulant. Suppose a patient with trauma coming to you with maybe post MVR and warfarin. You have to address it. You have to correct it. So monitor coagulation during massive transfusion with viscoelastic testing. That is very, very important. Very important to avoid hypocalcemia. Massive transfusion can lead to hypercitratemia, which can lead to hypocalcemia. Citrate chelates all your calcium ions, leads to hypocalcemia, which decreases your coagulation efficiency, leads to more bleeding. So it is very important to give calcium also at a fixed doses. Suppose you are transfusing 4 units, then you'll give one ampule of calcium, something like that. So let us understand something about viscoelastic testing. There are two tests, TEG versus ROTEM, more or less same thing. Both give us more realistic information. ROTEM gives us much more details about coagulation parameters than TEG, but they are improvising TEG also these days. What we need to understand is point of care tests. You cannot send it to the lab, wait for 3 hours and get it back. You can get INR, APTT also in the meanwhile if that is the case. So you need to do it point of care. You'll get it within 20 minutes. Okay. So tells us about real clotting time status. What advantage we have, PT, APTT, INR will not tell us about fibrinolysis, effect of heparin on coagulation and everything. So if there is fibrinolysis, we have to give Trenexa, which cannot be measured on a lab basis. Okay. And it cannot tell us the difference effect of antiplatelet or DOAC. Suppose a patient on DAPT coming to you with trauma, we won't know what is the effect of DAPT on the coagulation parameters, right? So it cannot also tell us about the effect of hypocalcemia and hypothermia. Why? Because we add additive calcium in this test. And hypothermia, no, again, because the blood is heated to 37 degrees Celsius and the test is run at that temperature. Even though patient has a temperature of 32 degrees Celsius, we are getting the results of coagulation parameters at 37 degrees Celsius, and we won't know the effect of hypothermia on these tests. So let us understand what is the effect of hypothermia on prothrombin time. So we have prothrombin time on the y-axis and temperature on the x-axis. At 38 degrees Celsius, you have a prothrombin time of maybe around 20. So as the temperature decreases to 28, your prothrombin time is increased to 40. That means your coagulation is hampered. That is why we need to maintain the temperature, warm all the blood products, warm all the fluids, whatever you're giving during massive transfusion or damage control resuscitation. So the last component of your damage control resuscitation is damage control surgery. What is it? There's no correction of anatomic deformity. Suppose a patient has come to you with a trauma and has a femoral artery rupture. You just go in, clamp or correct femoral artery and repair it. Do not do anything to the muscle. If there is an IVC shear, you will go correct IVC and come out. If there is grade 5 liver injury, you'll go pack and come out. Do nothing related to anatomic correction. If there's a perforation, you just don't do anything. You just clamp it and come out and reassess after 48 hours by re-exploration. This is damage control surgery where we take care of physiology rather than anatomy. So summarizing of what to put it on the paper, first you need to describe what is trauma-induced coagulopathy and how it affects and how each of your management affects trauma-induced coagulopathy. Then you have to elaborate on each component of DCR, where we'll start off with permissive hypotension, restrictive fluid administration, your target SBP, your target how much fluid you will administer. Then coming to hemostatic resuscitation, role of Trenexa, crash trial, balanced blood products, where you'll talk about proper prompt trial and what is balanced blood product administration, how is it helpful. Then massive transfusion protocol, how is it helpful. In a massive transfusion protocol, you'll talk about viscoelastic testing if possible. Then how hypothermia affects your coagulation status and bleeding, and what you'll do to prevent hypothermia. What all can you do? You can actively warm the patient, you could actively warm the blood products, and all those things. And what is the role of damage control surgery and what is damage control surgery? I hope you have understood, and hope you guys do well in the exam. Thank you. If you have any questions, you can ask me.
That's excellent presentation, Dr. Rajat. Just a query. Now people have started including this calcium also in this deadly triad nowadays. They say that make sure that you correct the calcium also. How much is there evidence from that perspective regarding calcium per se, or it's just a logical, physiological thing to do it?
I could not find any trials per se, sir, but I feel definitely a physiological thing and a logical thing, because we often see calcium of 0.6, 0.8 many times when we are transfusing, and it is very important to correct. Otherwise, it has very big implications.
Okay, that's great. Any further questions from the audience?
Sir, one question, sir. Sir, is there any special advantage of doing viscoelastic testing over conventional PT-INR and fibrinogen level? Is there an evidence base, like if there is a reduction in number of transfusion or some mortality difference, or is it the report will get in?
There are many advantages. So the most important advantage is it gives us the real-time status. So if you are doing PT, APTT, INR, no, you remove the components of platelet and assess only those components. You don't know what is the effect of platelet, or you don't know what is the effect of fibrinogen on these things. So that gives us an edge with regards to TEG or ROTEM. Second thing, you will get the test within 20 minutes. And third thing, you will have hyperfibrinolysis and all those things which cannot be measured, and your fibrinogen levels will take a lot of time from the lab to come. And fourth thing, the evidence is there for cardiac surgery, liver transplantation, and trauma, and nowhere else. Especially in CLD patients where protein C levels will also be low, and you have INR of 7. Even though INR is 7, you won't have any bleeding from in these patients. In such scenarios, you have strong evidence to do viscoelastic testing, and it reduces the number of transfusion required also, especially cardiac surgery, liver transplant, and trauma.
That's a wonderful talk, Dr. Rajat. I have a couple of questions here. So you have told about the permissive hypotension. So whether it is universally applicable, say for example, like for example, traumatic brain injury, do we need to maintain what is the target of the systolic blood pressure?
So as I mentioned in my slides, there are few contraindications for permissive hypotension, and one of the contraindication is traumatic brain injury, where we'll have to target a certain cerebral perfusion pressure to maintain the blood flow to the brain. Time is brain in traumatic brain injury, so we'll not include those set of patients for permissive hypotension. So second contraindication will be pregnancy, pediatric patients, and those patients with compartment syndrome also. In these set of patients, we'll try to avoid permissive hypotension. And there are no trials or observational studies also, which it is unethical to perform any studies of permissive hypotension in a patient with traumatic brain injury, because we for sure know that hypotension leads to increased brain damage.
Secondly, you have spoken about the damage control surgery, okay? So as to maintain only the physiological reserves, not the anatomical correction per se. And do you happen to know what is the duration that has to be done? I mean, the duration of the damage control surgery.
Duration of damage control surgery, usually what is generally followed in all Apex trauma centers all over the country is that so they will explore and they will leave the patient on for 24 to 48 hours. If they're confident, they'll explore at 24 hours. If not, then will depending on the physiological status of the patient. If patient is still in DIC, in wheezing and everything, they'll take up after 48 hours. If not, if they're confident about the hemostasis and everything, they'll re-explore after 24 hours only.
Okay, thank you.
Thank you, Dr. Rajat. It was an excellent topic. Now we'll invite Dr. Vinay. He's one of dynamic consultants from Manipal Hospital, Old Airport Road. He'll be talking about venous thromboembolism and its management. I'll let Vinay take over. Dr. Vinay, please.
Good evening, sir. Can you hear me?
Yeah, we can hear you, Vinay.
At the outset, I would like to thank Dr. Rajvardhan, Dr. Raghavendra Deshpande, and the entire Sarjapur team for conducting this one. So I will be discussing about venous thromboembolism. In the next 20 to 25 minutes, we will understand what are the risk factors, how do we assess the risk assessment for VTE, how do we assess the bleeding risk, and also the diagnostic workup for VTE and management. I have restricted it to prophylaxis only because of the time constraint. So coming to the introduction, VTE includes deep vein thrombosis and pulmonary embolism. In practice, 2/3 accounts for the DVT and 1/3 as PE. It is the top 3 underdiagnosed illnesses on autopsies after MI and stroke. The incidence ranges from 10 to 60%, depending on the cohort of the patients under the study. And also the incidence depends upon the thromboprophylaxis status. As we can see here, the incidence with thromboprophylaxis, without thromboprophylaxis ranges from 13 to 31%, whereas with thromboprophylaxis ranges from 5 to 23%. Hence, the VT risk is not eliminated with thromboprophylaxis, and also the continuous surveillance is necessary. Coming to the risk factors for venous thromboembolism, half of the VT events occur during the hospital admission, and 24% of them being due to the surgical reasons and 22% due to the medical reasons. The risk factors for VT includes cancer, older age, prior VT, central lines, immobility, vasopressor requirement, and other things. 40% of the hospitalized patients have 3 or more risk factors for venous thromboembolism, and also the thrombosis risk persist even post the discharge from the hospital. The risk factors can be categorized as general risk factors and also the risk factors specific to the ICU environment. Coming to the risk assessment model, the 3 major risk assessment model for the medical ICU patients are the first one being the Padua, followed by Improve VTE and the Geneva risk factors. These are available as online calculators, and all of us can do the calculation in our patients. According to the Padua score, 0 to 3 being the low risk, where the incidence of a symptomatic VT is 0.3%, whereas score of more than 4 is considered high risk, and in them 2.2% developed symptomatic VTE despite thromboprophylaxis, and 11% of them develop symptomatic VTE if not receiving thromboprophylaxis. According to the Improve registry, if all the risk factors of the Improve score are present, the incidence of symptomatic VT is 8 to 11%, and if none of them are present, it's anywhere between 0.4 to 0.5%. As per the Geneva registry, the less than 3 points is considered low risk, and the incidence is 0.6%, and more than 3 points, the incidence of VTE being 3.3 to 3.5 risk. Now we are done with the medical risk assessment. We come to the surgical risk assessment, the non-orthopedic of non-orthopedic patients, which is done by the Caprini model. And similar to the medical patients, the surgical risk category is categorized into very low, moderate, and high risk. And the incidence of symptomatic VTE patients ranges from 0.5 to in the very low risk category to 6% in the high risk category. In all these patients, we need to remember we are only accounting for the symptomatic VTE presentations. Coming to the orthopedic surgical risk assessment, they have classified, and this is the most important cohort where the VT is very important, and the risk and the peak incidence is between 7 to 14 days, and they also are at higher risk of bleeding events. The high risk surgeries of the high risk orthopedic surgeries include the hip replacement surgery, the knee replacement surgery, and the hip fracture surgery. And all these are considered high risk. The rest of the orthopedic surgeries are considered low risk as per the risk assessment model. Now we know about the medical, surgical, and orthopedic surgical risk. We come to the assessment of the bleeding risk. So the bleeding risk is given by the improve risk assessment model, which gives us a major bleeding, which gives us a probability of major bleeding and also clinically relevant bleeding. The major bleeding was defined as a drop in hemoglobin of more than 2, or requirement of more than 2 Paxils, or exsanguinating hemorrhage, or bleeding into one of the critical areas. Now we know about the bleeding risk. We also need to know about the additional patient-related risk factors, which can serve as a contraindications to initiation of thromboprophylaxis, which are active and significant bleeding. Very importantly, epistaxis and menstrual bleeding are not contraindications. Intracranial hemorrhage serve as a contraindication. Severe coagulopathy and bleeding diathesis, platelet counts less than 50,000, and also bleeding into one of the major organ spaces, and also anticipated or a recent epidural or any neuroaxial anesthesia. Now we know about the incidence, the risk assessment, and the bleeding risk. We come to the diagnostic workups. The diagnostic workup of VTE, to choose an appropriate test, the very important first step is to identify the pre-test probability. The pre-test probability scores are well defined for upper and lower limb DVT scores, for upper and lower limb DVT. And based on the pre-test probability, we apply an appropriate diagnostic test and establish a post-test probability of VTE. The common diagnostic tests which are employed are ultrasound, laboratory tests like D-dimer, and other radiological investigations like CTPA, CT, and MR venography, and also the VQ scan. Coming to the clinical prediction of PE, I will rush through this because most of us are aware, which is done with the help of reverse Geneva or the Wells score, where the pretest probability of more than 50% is considered as high pretest probability, and 20% being low, and 20% being intermediate, and less than 5% being a low pretest probability. This is very important, as we know this algorithm where if there is an intermediate to lower pretest probability, we do a D-dimer and then proceed with the CTPA, or else in patients with a high pretest probability, we directly go ahead with scans. So one important thing which we need to remember is the utility of VQ scan. VQ scan is not utilized when there is a pre-existent lung disease or there is an abnormal X-ray. And also the prerequisite for a VQ scan, of course, apart from the availability, also there needs to be a center. I mean, the center need to be expert in interpretation of VQ scans. So choosing between the VQ and CTPA after a low or intermediate pretest probability individuals being VQ scans, CTPA is preferred in most of the situations, especially when there is a pre-existing lung disease or an abnormal X-ray, whereas VQ scan is preferred when there is a risk of renal insufficiency because of the contrast and radiation related adverse events are a concern for the performing the scan. So coming to the clinical prediction of the DVT, the Wells score for the leg DVT stratifies the patient into high risk, high pretest probability, intermediate, and low pretest probability. And the constant score for the upper limb extremity DVT stratifies the patient into likely and unlikely. This is very important based on these pretest probability clinical scores. In patients with high pretest probability, we do a serial ultrasound scan. And we know that they do a 4-point or a 2-point compression scan along with the Doppler studies. If there is high pretest probability and if the scan is negative, we perform a serial ultrasound anywhere between 4 to 7 days. So continuous surveillance in a high pretest probability patient whose compression scan turns out to be negative, and serial scans are necessary, and continuous surveillance of the patient. In patients with low pretest probability for DVT, D-dimer is recommended as the first test to exclude the presence of a DVT. Coming to the management, I stick to only prophylaxis in the interest of time. So what are the options which we have? Pharmacological and mechanical anticoagulants, as we all know, ranging from low molecular weight, unfractionated direct oral DOACs, vitamin K antagonists, and also antiplatelets in specific cohorts such as orthopedic surgeries. Coming to the mechanical prophylaxis, intermittent pneumatic compression devices, graduated or graded compression stockings, venous foot pumps, and IVC filters are also option in certain scenarios. Coming to the pharmacological options, the most commonly used are enlisted in this table, which we do use in our regular practice, being enoxaparin and dalteparin, apart from fondaparin. Coming to the prophylaxis amongst the medical patients, as we all know, in acutely ill medical patients, thromboprophylaxis with unfractionated heparin is preferred over no parenteral anticoagulation. And between the low molecular weight heparin, between the low molecular weight and unfractionated heparin, low molecular weight heparin and fondaparin are recommended over the unfractionated heparin. In acutely ill medical patients, the pharmacological VT prophylaxis are preferred over the mechanical ones, whereas DOAC's utility in medical patients are limited because of their major adverse event being the bleeding tendencies, and also the addition of mechanical to the pharmacological prophylaxis, our utility as a combined nature is not helpful, which has been proven with major trials. Coming to the prophylaxis in the post-surgical patients, the post-surgical patients, we use a standard short-term up to 14 days or until the patient mobilizes. Low molecular weight is preferred. In patients not suitable for pharmacological prophylaxis, we use mechanical, and post-major surgery with other risk factors. Here, there is a role of combined mechanical plus pharmacological as per the ASH guidelines. And where do we consider using extended prophylaxis? That is anywhere beyond 14 to 20 days, 14 to 21 days. That is beyond 3 weeks of thromboprophylaxis are considered in hip surgeries and cancer surgeries and immobility post major surgery, or there is a history of a recurrent VTE. Coming to the mechanical DVT prophylaxis, only in surgical patients, there has been some data which says that the pneumatic compression devices are preferred over graded compression stockings, but in rest of the ICU cohort, both pneumatic compression devices and the graded compression stockings are equal. So apart from this, we need to know what are the recommendations against thromboprophylaxis in specific surgical subsets, such as laparoscopic cholecystectomy patients, radical prostatectomy, TURP, and also in patients undergoing neurosurgical procedure. Coming to the most important cohort, the orthopedic surgical patients. As we all know, the low molecular weight heparin is the first choice. And hip arthroplasty, there is an indication to prolong the anticoagulation up till 35 days with transition to with possible transition to aspirin in selected subgroup of patients after 5 to 10 days. And also in knee arthroplasty patients, 14 days and transition after 5 to 10 days duration. And hip fracture, the duration of thromboprophylaxis can be extended. It needs to be up to 35 days. The rest of the orthopedic surgeries, it is a short term, that is anywhere between 7 to 14 days or until the patient mobilizes. This is a specific subgroup where DOACs are used in the doses recommended here. The rivaroxaban, apixaban, and dabigatran are the most common used DOACs. And except for hip fracture surgery, in the rest of the patients, that is knee and hip arthroplasty, the DOACs are considered equivalent to low molecular weight heparin. In which cases do we transition over to aspirin in cases of hip and knee arthroplasty? Are where there is no other additional risk factors for VTE and there is no indication for long-term anticoagulation, and there are no lower limb or other accompanying fractures in the previous 3 months, and the surgical procedure which the patient underwent is purely elective, unilateral, and patient was mobilized within 24 hours of surgery. In these patients, we can transition over to aspirin after 5 days of low molecular weight heparin. So now we know the risk factors, risk assessment, bleeding risk, and the choice of thromboprophylaxis. We need to know how good are we complying to these guidelines. So coming to the compliance of thromboprophylaxis, adherence to thromboprophylaxis is of course poor. The global endorsed multinational studies showed that the adherence to ACCP guidelines was only 50.2%. The Indian endorsed data showed that it was much more worse at 17.4%. And another study or the another registry, the PROVE registry, showed that among the patients who experienced symptomatic DVT, among the hospitalized patients, only 7% of them were on thromboprophylaxis. Among the intensive care cohort from Tori et al. Showed that the thromboprophylaxis, the patients receiving thromboprophylaxis was anywhere between 44 to 47%. So overall, the compliance to thromboprophylaxis is quite poor. So to conclude this, venous thromboembolism and thromboprophylaxis is an under-recognized problem among the critically ill patients. Risk assessment and stratification of all patients should be done within 24 to 48 hours of ICU admission. Assessment of bleeding risk and other contraindication needs to be addressed. Appropriate dose, duration, and de-escalation of the thromboprophylactic agent. Stick to the bundled care. Nurse-driven approaches. Probably most of the times, even the nurse would have alarmed us regarding the, thromboprophylactic agent not there on the drug card. Surveillance for DVT in high-risk patients, despite thromboprophylaxis, has to continue because the patients do experience DVTs despite anticoagulation. And we need to employ thromboprophylaxis stewardship, and regular audits and quality improvement programs are needed to improve the adherence to thromboprophylaxis, especially with the data showing that the adherence to thromboprophylaxis is very poor. Thank you.
Thank you, Dr. Vinay. That was an excellent talk. And especially for the exam going students, what all points they need to cover. Just a query from my side, whether you need to include, if they give a question as only venous thromboembolism, whether you need to speak about pulmonary embolism or no need to speak about pulmonary embolism?
Possibly venous thromboembolism is a spectrum in ranging from DVT to pulmonary embolism. We do need to speak because at least we need to cover it up. So I just touched up upon the prophylaxis and the risk factors assessment for pulmonary embolism in the interest of time. But I feel that we have to at least tell about. Say that.
The question is how much time we'll have for. For example, if we keep a time of 15 minutes for each question in the exam, I think it will be slightly difficult, I guess, right?
Totally
all the aspects. I think it also depends on you people, what you're going to speak about and how much you want to cover. I think better to touch upon pulmonary embolism. I know it's quite difficult to cover each and every aspect of it, but part of it we can cover, I guess, right?
Yeah, totally agree, sir.
Okay. Anybody else? Any other thoughts? Any other questions?
Sir, what is the prophylactic dose of unfractionated heparin, sir?
Prophylactic
dose,
unfractionated heparin is usually not preferred as per ASH, ACCP, but if at all we are using, it is 5,000 twice daily.
5,000 twice daily, sir. If the patient is having CKD and at that moment we are not able to give LMWH, so in that moment we can select UFH, no, sir?
We can use either, or else we can use for lesser accumulating agents such as dalteparin, which is much more better in comparison. Even the PROTECT trial, which the landmark NEJM trial, used dalteparin. Yeah.
Okay, sir. One more doubt, sir. If the thrombus burden is very high, so before doing thrombolysis, is it necessary to put IVC filter, sir? If the thrombus is sir,
there is no role of prophylactic IVC filters, just for prevention of propagation of DVT.
Sir. Okay.
In fact, it is harmful. It is known to propagate the clot, and it increases the mortality. There is no role for prophylactic IVC filter insertion.
So is there an incident of occurrence of pulmonary emboli when you are started treatment for peripheral DVT, sir?
We need again. Then it depends on whether the patient is categorized into which severity of pulmonary embolism, and then we go. As per either catheter-directed thrombolysis or systemic thrombolysis.
Okay, sir.
Either
Sir,
full dose or half dose. Yeah.
One more last doubt, sir. If the patient is present with septic shock, sir, is having thrombocytopenia, like platelet count is less than like 15-20,000 like that, and there is a massive thrombus in common femoral and popliteal and anterior tibial. So in that case, sir, directly we need to go with catheter or else?
If there is a pulmonary embolism, definitely it's a catheter-directed thrombolysis.
No,
is
sir.
the way.
No, if the thrombus is in common femoral. Common femoral vein में thrombus है, sir. Patient is in septic shock with thrombocytopenia.
Catheter-directed
Catheter-directed.
We definitely cannot initiate, because as I showed you in one of the slides, platelets being less than 50,000 is a contraindication.
Yes, sir.
So we have to wait. Sometimes there is a shady evidence that use of mechanical can even propagate or dislodge things like that. So things are not clear. But catheter-directed thrombolysis, if the clot burden is high, is a definite possibility.
Hello,
Definitely
sir.
no. Definitely no pharmacological or chemical thromboprophylaxis. Yeah.
Thank you, sir. Thank you, sir.
Sir, I have one doubt. Can I ask?
Yeah.
Sir, I recently read this ESC guideline of pulmonary embolism. In that they have written कि if the patient is unstable, hemodynamically unstable, we are preferring thrombolysis, but they said कि we can use unfractionated heparin also. So I didn't get that point. In unstable patient, is there any role of unfractionated weight heparin? Or means
Definitely no.
hemodynamically unstable means what they want to say exactly? I didn't understand that. So I'm asking.
Hemodynamically unstable, that is high risk pulmonary embolism. Definitely we have to do either we have to go for thrombolysis or catheter-directed thrombectomy, which have come up in a few centers. So definitely no, not we are not bridging it over with unfractionated heparin or things like that. Definitely we have to go with catheter-directed thrombolysis or systemic thrombolysis, along with initiation of therapeutic anticoagulation.
Okay.
And half dose thrombolysis comes into picture only in intermediate high risk.
Sir, which agent will you prefer for prophylaxis in venous thrombolysis in the case of suspected heparin-induced thrombocytopenia as well as an acute kidney injury? So in that case, the platelet count is somewhere around 70 to 80,000, and patient is high risk for thrombus formation, and patient is having acute kidney injury also. So in this situation, which drug will you prefer, sir?
I actually missed your point. I think I had some disturbance in the background. Can you just repeat it very quickly?
Sir, in a patient with suspected heparin-induced thrombocytopenia with a platelet count of 70 to 80,000 and with acute kidney injury, sir. So in this group of patient, which agent will you prefer for prophylaxis, sir?
So either we can go for, low molecular weight heparin has per se, even though it is lesser than unfractionated, it is still at risk of having heparin-induced thrombocytopenia. We can use fondaparinux, or if at all it's not in the, if at all it's an orthopedic surgery.
We can consider
if at all, only if it is orthopedic surgery cohort, only we can switch over to DOACs. Otherwise, whether it's in the surgical or general surgical or cancer surgery or medical patients, DOACs still we cannot use. Yeah.
Sir,
mechanical, definitely mechanical we have to use. Yeah.
Okay. Sir, one more question. In a patient with acute ischemic stroke or intracranial bleed, after how many days will you start pharmacological prophylaxis?
So ICH, at least if the patient is not on, if the patient was not on any blood thinners, at the end of 2-3 days, where the clot expansion risk has reduced significantly. At the end of 48 to 72 hours, we can initiate. If the patient was on blood thinners, that is the reason causing the, that is the reason causing the ICH. Probably it can be delayed. Whereas in cases of SAH, 24 hours after securing the aneurysm, DVT prophylaxis can be initiated. These are the two things, yeah, ICH and SAH.
Sir, one more question, sir. Sir, brief scenario, sir. Patient is hello, sir.
Yeah, I can hear.
Sir, patient is like post mitral valve prosthesis. Mitral valve prosthesis are there, sir. He was on warfarin, so because of that he got ICH. So for which he got operated.
Okay.
So post-operatively, at what time we will decide, sir? Like for this processes, we need to give anticoagulation. So if we are delaying it, stuck wall thrombosis वगैरह होने का chance तो है. उसमें कैसे, sir?
Yeah. So there are no clear-cut guidelines for this. We have experienced multiple such scenarios of late. So, but definitely therapeutic anticoagulation is risky up till 4 weeks. There is a meta, some Japanese, I think I just have it, I can share with you. So up till 4 weeks after an ICH, therapeutic anticoagulation, especially with a coexistent mechanical mitral valve or any other prosthesis, cannot be given. We will have to explain the family because it's a tough rope to walk on catch-22 situation. We will have to initiate, let's say at the end of 3 to 5 days probably, where the clot expand or the hematoma expansion has faded away. And if at all we are initiating, we will definitely not initiate DOACs or warfarin. We are going to prescribe enoxaparin, where the reversal can be given, or the duration of action is very short.
Okay, sir. Okay, sir. Thank you, sir.
Thank you. Okay, thank you. If any other
Thank you, Dr. Vinay, for this wonderful talk. Okay, so we will move on to the next speaker, Dr. Darshan, who is a consultant at Baptist Hospital, Bangalore. So he will be talking on the time-dependent antimicrobials, examples and mechanism of actions. This has been asked in, I think, in 2019 or 2020 DrNB questions. So over to you, Dr. Darshan.
Good evening, everyone. Thank you, Dr. Raghavendra, and the whole Sarjapur Manipal team for this opportunity. I owe most of my learning to Rajvardhan sir from where it all began. So without wasting much time, I think so we'll go to the next topic. As Dr. Raghavendra already mentioned, this has been one of the questions which have been asked previously, and one of the common things that can be asked even in the practical sessions as well. So delving into the topic per se, so whenever a question gets asked in the exam, better to answer them under headings. So that is what they look at. Probably we might be able to answer well if we actually formulate a plan. So I would be approaching the particular topic under these headings, that is the definition or an introduction, diagrams if necessary, salient points of that particular topic, examples if any are there, bedside application, and special circumstances including evidence. So going to time-dependent antibiotics, there are a class of antibiotics whose effectiveness is primarily related to the duration of time of that particular drug, which remains above the minimum inhibitory concentration for a target bacteria. So the important thing that we need to remember is the duration of time above the MIC and the specificity that is to that particular type of a bacteria. So the killing of bacteria is usually more possible if the total time of the antibiotic remains above the MIC. Okay. So how exactly an MIC curve looks? The diagram usually should contain an x-axis which is labeled as time, a y-axis which is the concentration. Okay. Usually the graph which is mentioned is for a 24-hour period, which usually gives the definition of MIC as well. Okay, so in this particular thing, what important thing that we need to remember is the MIC cutoff. Okay, so most of the times what happens is the time dependent antibiotic killing is this particular region which we need to look, and this gives us the T more than MIC. So there are multiple antibiotics which are present, they follow this kind of pharmacodynamics. Okay, So this is the diagram that we all know. So if you taken that the injection is given at this particular time, it reaches a peak concentration and then comes down, correct? And this what we take into picture as the time above the MIC. So what are the salient points or characteristics of antibiotics which follow time-dependent killing? It firstly depends on the amount of drug which is above the minimum inhibitory concentration. The killing rate, we need to remember, does not significantly increase by increasing the concentration of the drug. Okay, that it's totally a different game. That is the concentration dependent killing. So here we need to understand this point clearly. And because of this, that is the T more than MIC, it requires frequent dosing. So this is one of the studies which was done way back in 91, which showed different classes of antibiotics. But what I want you to see is ticarcillin. Ciplox is fluoroquinolone. It depends on concentration dependent killing. So if you see here, right? So what we can see here is the y-axis shows you the colony forming units of the bacteria, and the x-axis shows the time in hours. It's very clearly noted here is by increasing the concentration of that particular drug beyond a particular MIC, say up to 4 times the MIC value, which is usually required, gives a better bacterial killing in a time-dependent curve. But going beyond that, that is 16 times the MIC or 64 times the MIC, they did not have much beneficial effect. Okay, so all that mattered is just the time of the drug above the MIC. That is what matters, not the concentration, which usually is depending on increasing the dosage of the drug. So coming to what is meaning of time over the MIC, you can see here, first, there are multiple dosing that have been given over a period of time, right? This is the first thing that we start here. It goes up, and the next frequent dosing should depend on a particular time interval. So based on the type of antibiotic that we use, and depending on the class of antibiotic, the frequent dosing would be given. What usually is suggested is it should cover 40 to 60% of the dosing interval before we choose the next antibiotic timing. Okay, so if at all you're choosing, say, suppose carbapenems, it should be there up to a level of more than 40% of the drug duration. If it falls below that, the efficacy of that particular drug would be lost and probably would require a loading dose to be given to achieve the steady state. Okay. So higher percentages sometimes have also been required. That is more than 80% of the MIC itself. So what I mean by 80% is, for example, few of the things require 40 to 60%. Probably if it is an 80% curve, the dosing should be given at a much earlier phase. That is very higher up. Okay. So that is what is the most important thing in a time-dependent type of pharmacokinetic principle. Okay. Concentration time is something that matters only to maintain the dosing interval. Dosing concentration is only to achieve the level of the drug above the MIC. Okay.
No.
So what exactly we need to remember here is this concept of loading dose. Okay, so whenever you are talking about loading dose in time dependent antibiotics, I told you, if at all the dosing interval is above 60%, probably the steady state is already achieved, and then you can start giving the second dose. But if you give beyond that particular period, so the antibiotic might come down, and to achieve the therapeutic concentration, we might have to give another loading dose. To avoid this, the efficacy becomes better if you give it at a 40 to 60% dose. That is what has been evaluated in multiple trials. Okay. So what are the optimization strategies that are required to understand these things? You remember that time-dependent antibiotics usually require a shorter dosing interval. Always consider giving extended or continuous infusions. There have been multiple trials that I'll be discussing in the later slides. Dosage adjustment would be depending on the patient factors, depending on the comorbidities, volume of distribution, hemodynamic status, etc. Sometimes even the organism and that particular MIC also would guide the dosing, and also the site of infection. Okay, so coming to the understanding of what I mean by the 40 to 60%. So this is one of the trials which was done to understand this particular concept of maintaining the time above MIC for more than 50%. Okay, if you see the tissue growth of a bacteria in a lung, okay, So this is what is compared with time over MIC. So you see here, till the drug was at the concentration of between 40 to 100%, there was decreased production of bacteria, or multiplication of the bacteria was very minimal. As soon as the time above concentration dropped below this, you see an exponential growth in bacteria here. So this is what they mean by time over MIC and the concentration requirement being more than 40%. Okay, so hope I'm clear up till here. So to understand these things quite simple, you always maintain the concentration of that particular antibiotic for more than 40%. So keep 40% as one of your understanding, cutoffs. Different antibiotics have different cutoffs. The 40 to 50% is the usual thing that we need to remember. Okay. Always remember, because of this concept, the post antibiotic effect of time dependent antibiotics is very poor, or it is very minimal. Okay, so I'll talk about post antibiotic quite briefly in the coming slides. Okay, so examples with mechanism is what they had asked. So up till now we have discussed about what is time dependent antimicrobial killing. So coming to the first example, beta lactams, the mechanism is inhibition of cell wall synthesis by binding to the penicillin binding proteins. Examples are penicillin group of drugs, like ampicillin, amoxicillin, or ticarcillin. Macrolides are the other group of antibiotics that you need to remember. They inhibit protein wall synthesis by binding to the 50S ribosomal unit. Examples are azithromycin, erythromycin, and clarithromycin. Okay, what starking evidence you see here is, we were talking about shorter frequent dosing, right? But if you see, most commonly we give azithromycin as an OD drug, and beta lactams probably a BD or a TID type of dosing, right? So this can create a confusion. Even though it is an OD drug, why is it like a time dependent killing, right? So what matters is how the drug is metabolized and eliminated. So depending on that, if that particular concentration is remaining above the MIC, that is sufficient enough to get a antimicrobial effect. Okay. So coming to lincosamides, that is the other group of time-dependent antibiotic killing. They are again protein synthesis inhibitors which bind to the 50S ribosomes. Examples are clindamycin and lincomycin. The glycopeptide antibiotic, that is vancomycin, which we use for most of the MDR drugs, especially the MRSA. It inhibits the cell wall synthesis by binding to the D-alanine terminus of the peptidoglycan precursors. So usually what we do is trough levels, right? So trough levels are usually done for this particular understanding of time-dependent antimicrobial killing. So what you want is that particular concentration of vancomycin, roughly around 20, is what is given in most of the research, and that is what is required for effective antimicrobial activity. Because we all know that the side effects associated, or the adverse drug reactions associated with vancomycin are higher if higher levels are reached. So that is one of the reasons trough levels is necessary in mostly an idealistic approach. But yeah, if you have this is one of the things that we can frequently get it quite easily as well. Coming to the other drug, that is carbapenems, the mechanism is similar to that of cephalosporins. It is a cell wall inhibitor itself. Okay, it binds to the penicillin binding protein, and usually tries to prevent the peptidoglycan cross-linking, which is going to break down the effective cell wall, and because of which there will be antimicrobial killing. The cell wall destabilization is what happens because of this, and then that leads to cell lysis. It also has a highly resistant mechanism for beta lactamases when they are present. Cephalosporins is the last example that I would like to mention. Again, the mechanism of is cell wall inhibition by binding to the penicillin binding proteins. It also disrupts the peptidoglycan layer, thereby interfering with the strength of the cell wall structure. So coming to a note on post-antibiotic effect, it is the continued suppression of bacterial growth after an antibiotic falls below the MIC value. This usually depends on the type of antibiotic, that is the antibiotic class. It depends on the type of species, whether it is gram-positive or gram-negative type of an organism, or exposure conditions. It also depends on conditions like probably a septic shock or a hemodynamic status. All of that also matters for post-antibiotic effect. Always remember, post-antibiotic effect is better for aminoglycosides, as that is the concentration type of antibiotic killing, as compared to time-dependent antibiotics like beta-lactams and vancomycin, which have a smaller post-antibiotic effect. Okay. Coming to the evidence of timing the antibiotics. So till now we spoke about the shorter intervals, achieving a concentration of more than 40% in the duration interval to get effective antimicrobial killing. There have been many trials which have been done way back from 2000 onwards. So what Mouton et al. Saw initially was in a gram-negative sepsis patients, whether continuous infusion of ceftazidime with an intermittent dosing of ceftazidime had a positive outcome. What it revealed was continuous infusion was better in achieving target as compared to intermittent dosing. There was some amount of decreased ICU stay. Mortality benefit was also present. But this numbers quite and the end results were not fairly it was a smaller trial, just to say that they had many drawbacks or limitations. Following Newton et al., Lloyds also did another example, other trial for nosocomial pneumonia, where he compared the continuous infusion of peptides with intermittent dosing, which also was positive, which showed that continuous infusion of piperacillin tazobactam was superior as compared to intermittent dosing. Daly and Wolf also came back with similar results for beta-lactams. With this background, with Daly and Wolf and the previous trials, there were two other major trials, that is the RCTs which were done, that is the BLINK2 and BLINK3 trials. These trials actually compared the beta-lactams, whether continuous infusion was better over intermittent infusion, but unfortunately no 90-day mortality benefit was seen. Preceding to the publication of BLINK3, there was another trial in 2023, that is the MERCY trial. Even that showed non-significant reduction of around 2% for meropenem. So probably still robust evidence is not available despite multiple trials being done. What usually happens is the effects of subgroup analysis and other data needs to be evaluated. Probably patients with sepsis, with septic shock, probably these kind of patients might still benefit with infusion over a longer period of time. So what I understood by all of this is no robust evidence yet for us to set guidelines that continuous infusion is better as compared to intermittent dosing. Patients with septic shock, patients with a larger volume of distributions, infusions might be better because it gives a better understanding of the PK/PD principle. Patients with augmented renal clearance, again, will have an effect on the PK/PD, even with time-dependent antimicrobial killing. In such cases, probably an extra dose would be necessary. For example, carbapenems will be given in a TID dosing. Probably we have to give it in a QID dosing in patients who have augmented renal clearance, which is seen in patients with sepsis, burns, etc. Multi-drug organisms is another place where they have seen that continuous infusion is supposedly having better results as compared to the ones with intermittent dosing. So if I was given the paper, this is what I actually would have written. So summarizing, the question was time-dependent antibiotics, examples and mechanism. Start with the definition. Then after that, make sure that you give a graph or a diagram with quite proper labeling. Okay, so it depends on the labeling of the x-axis and the y-axis and what exactly we are looking at. Okay, so the other two principles that we need to know are the area under the curve and the concentration dependent killing. What are the key features of time dependent antimicrobial killings that has to be mentioned? Okay, the drug concentration being time more than MIC. Also remember, increasing the concentration of drug above the MIC does not give better outcomes or better bacterial killing. Okay, and most importantly, in time-dependent antimicrobial killing, the frequency matters. Coming to the frequency dosing interval, what does it depend on? We are speaking about the 40 to 60% dosing interval above the MIC. So the first dose, second dose, and third dose speak about loading dose as well here. Okay. So if we mention about this, the effective drug which remains about the MIC value will be higher, and which will help us have a better antimicrobial activity. Okay. So coming to dosing, always remember there are a lot of antibiotics in this particular mechanism, that is the beta-lactams, cephalosporin, carbapenems, and macrolides. They have a different type of dosing interval, but all that matters is the type of antibiotic and its PK/PD principle, which guides us to get that particular dosing interval. Okay. So other things that has to be considered in dosing is organ dysfunction, because it affects clearance. You need to consider about renal and hepatic. Dose adjustments are based on the comorbidities and the current probably renal clearance. Okay. Site also matters for dosing. Probably in a CNS dosing, the dose might be required. The dose required is usually higher as compared to other sites. So site is also one of the parameters which will affect dosing. The other thing that we need to remember is all the examples of antibiotic which follow the time dependent killing. I've already mentioned beta lactams, macrolides, cephalosporins, carbapenems, lincosamides, and glycopeptides like vancomycin. I'm sorry. So these are the things that we need to consider for one of answering, and then mention about the post antibiotic effect and evidence. Okay, evidence. When I actually wrote this down, as the first thing which came into my mind was only Blink. When I later went on and read back, I got the whole chronology in order. So probably these things. It would be enough to write up to 3 to 4 pages. Usually for a 10-mark question, the amount of space which is given is roughly 5 pages. So firstly, focus on what is asked for. Clearly the question was time dependent antimicrobial effect. The second part of the question was examples with mechanism of action. If at all the weightage for each question is given, follow that particular weightage. If things on time dependent killing was only 3 marks, just mention one graph and what are the salient features. Rest of the things need not be written. Then you need to focus about examples. In that particular time, if examples are ones which are carrying major weightage, probably a diagram would be beneficial. If you draw a proper diagram showing what type of antibiotics acts on, that is whether it is on protein synthesis, cell wall inhibition, so on and so forth, that would give you a better marking as compared to the others. Thank you.
That's a great talk, Dr. Darshan. Sorry, I missed your introduction. Dr. Darshan, I can understand why you were a gold medalist during exams. That's a quite precise and onto the point discussion we had during this one. All four were actually the very good talks. The quality of the talks were quite good, and especially from your exam perspective, you don't need to know everything, but you need to write. You need to write important points from the examiner perspective. Okay, so I came to know that your exams are coming soon. I'm not sure when exactly. My question will be: I know it's difficult to cover all the topics. If people put a message that any specific topics you want, we'll try to cover those things, because it's difficult for us also to cover all the topics at this point of time. And second thing is, I think most of us will be sharing the answers or PowerPoint or a handout, something like that, where what to write. The example, whatever Darshan showed, those are the simple things which you need to mention in the exams. Those things will be shared for you for easy, for to write the answer. Okay, that's it. Any further questions on this topic or anything per se? Dr. Raghavendra, Dr. Ashwardhan, anybody, any other speakers want to add up anything?
So most importantly, time is important, like you were mentioning with the previous talk as well. Whenever there is a particular question asked, first focus on what is the main question and time limit. So don't exceed the time. If you don't know, or if you have exceeded the time, please go on to the next question and come back to this if you have time in the end. So that is what is necessary in exam. Otherwise, unnecessarily, we'll be writing more for the same topic. Unfortunately, in the end, we might not be able to come back to this. So that is one practical thing that usually happens. Most of us go through that.
That's just a query. You leave a space after writing that answer. You leave some space so that you can come back and write something extra.
So we can do that, but what exactly NBE has done for all the DrNB candidates is one particular question that will have an earmarked page number. Like say, suppose question number 1 has to be written in page number 1 to 5. You can't
Oh.
write page question number 2 and 1 to 5 at that particular time, because these will be removed, and probably different examiner will correct one particular or 2 questions per se, something like that. So leaving space would be a little tricky. We are not supposed to. And the next question, say question number 2 has to be started in page number 6. It cannot be started at page number 4 or 5 if at all there is space. You need to leave that page blank. So that is one of the instructions which will be given. So one of the most important thing is please read the instructions carefully when you're writing. So they would have written what to do.
Okay, that's an important. Anybody else want to add up anything for this?
The thing is that from the examiner's, am I audible? From the examiner's perspective, so we better do an algorithm or the drawings, okay, figures. So if we do that, then it will be very easy for the examiner to glance your questions, answers, and in a way you can save the time.
Okay, I think that's it. We're done with most of the sessions, I guess. Thank you everyone for joining. Okay, please, if you want us to do any specific topic because exams are nearby, please let us know. We'll cover those important topics. Okay, thank you. And I will be sharing, if you want any of these notes, I think they're shared in the group already. If you want anything, you can message us individually. We'll share the answers of those questions. Okay. Okay.